Scene safe, BSI, determine number of patients, show mechanism of injury, call for ALS if needed, take C-spine precautions if necessary, pushing the patient, form your general impressions, and check for any apparent life threats. Assess the patient's level of consciousness using the APFU scale. Is the patient alert-oriented? Is he responsive to verbal stimuli, responsive to painful stimuli, or unresponsive? I'm going to start with our ABCs, starting with the airway. Does the patient have an open, clear, maintainable airway? If not, you're going to try and create one using head tilt chin lift or jaw thrust maneuver. If the patient is in C-spine, if that does not work, you use the appropriate airway adjunct, MPA, OPA, or a multi-lumen airway. Once the airway has been established, you're going to move on to breathing. Is the patient breathing on their own? If they are, do they have adequate tidal volume? Are the respirations an appropriate rate between 10 and 24? If they are, most likely just going to apply high flow oxygen via non-rebreather mask. If not, we're going to attempt to assist the patient's ventilations using positive pressure ventilation with BVM, matching the patient's respirations if they are breathing. After the breathing has been established, you're going to check circulation, going to check for pulse, and assess the skin condition. Does the skin feel pink, warm, and dry, or cool, calming, creamy? And we're going to assess for any signs of shock at this point. If there are signs of shock, you want to put the patient in the shock position, elevate the legs, try and keep the patient as warm as possible. After your ABCs have been completed, you're going to make your transport decision. Do you have time to stay and work on the patient, or do you need a priority transport? And you're also going to base that decision based off of your Glasgow Coma Scale. Once the ABCs have been completed, primary assessment is complete. Attempt to obtain a sample history from the patient. If they are unable, check to see if there's a family member or bystander by who may have at least seen the events leading up to. After sample history, you're going to start your secondary assessment. You're going to start at the head. You're going to check the whole cranium and scalp, palpating around. You want to check the patient's eyes. You're going to check their pupils, see if they are equal and reactive or not. You look for signs of raccoon eyes. Continue to palpate the rest of the facial structures, checking the mouth and nose. You want to check the patient's ears, checking for any signs of vital signs, palpating the cervical spine. We move down to the neck, check the trachea, see if it is midline or deviated, check jugular veins, and then move on to the patient's chest. You want to look for any obvious signs of trauma, and palpate around the collarbone, check the sternum. You want to check the patient's rib cage, make sure that that is intact. You're going to palpate all four quadrants of the abdomen. Check the patient's pelvis. Do a genital sweep. Continue on down to the lower extremities. Check for a distal pulse and PMS. If the patient is able to, have them push or pull against your hand, and without looking at their feet, ask if they can tell you which foot or toe you are touching. If the patient is unresponsive, check for pain stimuli. See if they'll respond to any sort of painful stimuli in the distal phalanges. Check the upper extremities. Same thing, palpate all the way down. Check for radial pulse and check for PMS again. And you're going to hover over the patient. Again, assessing the rest of the neck and spine. Do a quick once over of the back, buttocks. Place your long backboard. Roll your patient back onto the backboard. And then you are going to strap the patient down, prep for transport. You're going to manage any secondary injuries on scene if possible, or in the ambulance on the way to the hospital if the patient is a priority patient. After all that's complete, you're going to get your baseline set of vitals. After all that is done, you're going to reassess every 5 minutes for a critical patient, 15 for a non-critical patient, starting with your ABCs.